Hey everybody, I hope your semester is going well so far and nobody is in a total panic over this health assessment. Just remember to take it slow and easy and one step at a time. You will get it. Today we're going to go over the abdominal assessment. Let me pull up the PowerPoint for you here. You're going to want to make sure that you read the chapter, review the structures and the function in the abdomen. Okay, make sure that you know what lies underneath each one of the quadrants, so when you're doing your assessment you'll have some idea of what you're supposed to be feeling. Alright, let's just jump right into this. On your interview, your assessment interview, this is what you're going to need to be looking for. You're going to want to look at each and every one of these things with your patient. You want to ask the patient if they've had any changes in appetite or weight, and if so, to what extent. In other words, have they had a sudden weight loss or a sudden weight gain? If they've lost any weight or gained any weight, you want to see if they've attempted to do this. Ask about any difficulty in chewing and swallowing and when it first was noted. Does the patient have any food allergies or intolerances, such as belching or bloating or indigestion, lactose intolerance? And if they do, what kind of medications are they on for this and how often do they have it? Ask about any abdominal pain and have them point to the spot. You want to find out when it started and what makes it worse or better. How do they describe that pain and what are the characteristics of the pain, such as colicky pain or cramping pain, burning, dullness, stabbing, aching, things like that. What type of pain do they have? Is the pain relieved or worsened with food? This could be pointing towards ulcers. Is the pain associated with menstruation? Do they have stress? Do they have any signs and symptoms that go along with that pain, like fever or rectal bleeding, increased frequency in urination, any vaginal or penile discharge? Does the patient experience any nausea and vomiting? And if so, how often? And how much do they vomit? What does their vomitus look like? And is there any odor to it? Find out what they have had to eat in the last 24 hours before that episode starts and where they ate it. Were they in a restaurant, at school, or were they at home? You need to find out if they've traveled recently outside of the country, and if they did they drink any local water, eat any fruit, or go swimming? If they did go swimming, was it at a public beach or in a pool? You want to assess their bowel habits, such as the color, the consistency, how often, any changes in their habits, and does the patient use any laxatives? And if they do use laxative, how often do they use them and what type? Does the patient have any past abdominal history, such as surgeries or ulcers, gallbladder disease, hepatitis, appendicitis, colitis, any hernias that they remember? If they've had surgery, what was it for? And did they have any problems afterwards? When was the patient's last abdominal x-rays, studies, and if they did have them, what were the results? Assess any medications that the patient might currently be taking, as well as their alcohol habits and their smoking habits. Ask that patient to provide you with a 24-hour calorie count, starting with the previous morning. Find out about the patient's grocery shopping and accessibility to groceries. For some of your elderly, it might be a point that they only get lightweight groceries, so to speak, because they have trouble carrying the sacks. special considerations that you're going to have. For infants and children, you're going to need to ask the parents about breastfeeding or bottle feeding, when table food was introduced and what they introduced first, how often that child eats. Do they have they noticed any constipation in the child? If so, how often? Do they complain of abdominal pain? Is the child overweight? If so, how long has their weight been a problem? And what are the child's and the family's views on their weight problem? Okay? With adolescents, you need to do a 24-hour calorie count and assess what they've consumed. You also need to assess their exercise patterns and how they view their weight and their level of energy. With the aged, you also need to, like I said before, assess how they acquire groceries and how they prepare meals. Find out if they eat alone, if they have trouble swallowing, and what their bowel movements are like. If they report constipation to you, you need to find out what they define constipation as. It might not necessarily be constipation. Assess how much liquids they take in and how much fiber they take in. If they use laxatives, what type and how often. Also, you need to assess other medications that the patient might be taking that can contribute to constipation, like pain medication. Okay? Now, that's got your assessment. Let's go into the skills that you're going to need. With the abdominal assessment, you're going to use all 4 skills. You're going to inspect, you're going to auscultate, palpate, and then percuss. And if you'll notice, this is in a different order than you've been doing. You're going to inspect first, look at it, then you're going to listen before you ever touch, because if you palpate or percuss their abdomen before you auscultate, that is going to change their bowel sounds. It's going to change the frequency of their bowel sounds. Okay? Now, equipment you're going to need. You're going to need a stethoscope, that small centimeter ruler, skin marking pen, and alcohol. You want to keep that room warm because the patient is going to be tensing their muscles if they're chilly. Okay? Their head should be on a pillow with their knees bent or on a pillow. Their arms need to be at their sides or across their chest. Don't let your patients put their arms up over their heads, and put their hands up under their head, because this is going to cause abdominal tensing. You're going to have that patient urinate before you start in on the exam, and make sure that your stethoscope and your hands are real warm. You're going to want to talk to this patient in a low, soothing tone and engage them in conversation to help prevent them from tensing up on you. Ask the patient about any painful areas, and those are the areas that you're going to assess last to prevent any tensing from the pain. Okay? Now, on inspection of the abdomen, I've got here the 4 shapes that typically describe an abdomen in an adult or a child. You're going to want to stand at the right side and look down on the abdomen. You're going to stoop or sit to gaze across that abdomen, okay? You want to be on eye level with it. Your head needs to be just a little bit higher than their abdomen. Determine the profile of the rib margin and the pubic bones, okay? The contour describes the nutritional state and normally ranges from a flat to a rounded. As you see here, flat is right straight across. Your rounded is protruded a little bit up. Your scaphoid is for those that are undernourished or malnourished, and you will see that their chest is bigger, their pelvis is higher, and their stomach is sunken in. And then you will have one that's called the protrudent, which you will see with people that have ascites. Okay? The contour describes their nutritional state, like I said before. You should have a light, a secondary light. The lighting in the room needs to be good, but the secondary light will be used to send tangential light across their abdomen as you are looking. You want to look for any shadows as you inspect that abdomen. like I said, you want to stand to the right and look at it, and then you want to move down to the foot of the bed and observe the contour of the abdomen for any bulges, any visible masses, asymmetrical shapes, or indurations, okay? You're going to check for some symmetry of the abdomen as you're looking. Ask the person to take a deep breath in to further highlight any changes, or you can have them perform a sit-up without pushing up with their hands, okay? The umbilicus is normally midline and inverted with no discoloration or inflammation or hernias noted. If the patient has piercings, which are fairly normal, especially in younger ladies, you need to assess that umbilical area for any redness or crusting. And realize that if you're looking at a pregnant lady, that their umbilicus will be inverted and pushed upward while they are pregnant. Okay. Inspection of the abdomen skin. You're going to be you want the surface to be smooth and even with homogeneous color. It's a good area for you to look at the patient to judge pigmentation, because a lot of times it's protected. However, with tanning bed use, that might be difficult now. Okay, a common pigment that you're going to see is up in the upper photograph, and this is striae. They be silvery white, linear, jagged marks. Most of them are about 1 to 6 centimeters long. They will start out as a bright pink or purple, and then they will fade to the silvery color. What are striae? Striae occurs when the elastic fibers in the reticular layer of the skin is broken after rapid weight gain. It's from the prolonged stretching. You will see this in pregnancy and excessive quick weight gain. Recent striae, like I said, are pink or blue, and they'll turn silvery white. Now you will see these in a patient with Cushing's disease. You'll see the purpley blue striae, and it's due to excessive adrenocortical hormones causing the skin to be real fragile and easily broken with normal stretching of skin. So next we're going to look at the pigmented nevi or moles. They should be circumscribed brown macular or papular areas, and they are common on the abdomen. You shouldn't have any lesions present, although you can note some well-healing scars. And when you do, as in this second picture here, you need to make sure that on your chart on the body that you mark those scars and you designate how long they are in centimeters, okay? This is a good opportunity as you're assessing the abdomen to make sure that you have all of the information from your patient. They can have surgeries that they'll forget. So if you see a surgical scar or a scar on their abdomen, say, hey, what happened here? You know, and talk to them about it, find out what was going on. Veins usually are not seen in the abdomen. They can have some fine venous networks visible in thin people, and you can see some spider nevi or spider veins in those that have diseases like sclerosis of the liver. Okay. Normally you can see a pulsation of the aorta beneath the skin in the epigastric area, particularly in your thin person, and with good muscle relaxation, but they have to have good relaxation in that stomach. Okay. Respiratory movement, you're going to see that in the abdomen, particularly in men. You might be able to see some waves of peristalsis. They're usually seen in very thin people, and it will ripple slowly across obliquely on the abdomen. the patient should have good skin turgor of the abdomen. You need to pinch and see if the turgor goes back. On well-nourished people especially, you will have this. You're going to watch your patient's face to make sure that you're not causing them any pain. You need to assess the pattern of pubic hair. Normal growth in men is a diamond shaped, and in women it's a inverted triangular shape. You can see alterations in this normal pattern in endocrine and hormonal abnormalities and chronic liver disease. So if you notice that there is any changes in this, you might need to delve into those 3 areas. Okay? You want to make sure that that person is calm and comfortable and relaxed and lying quietly on the examination table. They should have a benign facial expression. They shouldn't be like my little man here with round lines and a red nose and crying, okay? Restlessness and constant turning to find comfort would be an indication of colicky pain, like gastroenteritis or a bowel obstruction, okay? Absolute stillness or resistant to movement usually occurs with peritonitis. If they've got their knees flexed up and have facial grimacing and rapid, uneven respirations, this is a very good indication that they are having some pain. Now, like I said before, we're going to auscultate the bowel sounds next. We don't touch until we listen, okay? On the abdomen, the easy way for me to remember this is look, listen, and feel. Okay? You're going to note the frequency and the characteristics of the bowel sounds. They originate from air movement and fluid flow through the small intestines. It's going to depend on how much time has passed since they've eaten, how long it's going to take for you to pick up bowel sounds. Bowel sounds should be high-pitched, gurgly, cascading sounds occurring irregularly every from 5 to 30 times per minute. You need to judge if they are normal, active, or hypoactive. Normal, active, hypoactive, or hyperactive, excuse me. Hyperactive sounds are going to be loud, high-pitched, rushing, tinkling sounds that signal an increase in the motility. One type of hyperactive bowel sounds that's fairly common is what you call your stomach growling, okay? A perfectly silent abdomen is very uncommon. You're going to have to listen for a full 5 minutes on your watch before you decide that bowel sounds are actually absent on these patients, okay? Now, after you listen to bowel sounds, you're going to want to do your vascular sounds. So, note the presence of any vascular sounds or bruits. All right, you're going to use firm pressure, check over the aorta, which is midline, right? And it's about halfway between your xiphoid process and your umbilicus. And then you are going to do your renal arteries, which are out a little ways towards mid-clavicular line, only not quite that far, about halfway between mid-clavicular line and midline, okay, and down about 3 centimeters, okay. Then you're going to move on down and do the iliacs, which are at the umbilicus, or just below the umbilicus, towards the mid-clavicular line, and then you're going to do the femoral arteries, okay? And I have noted, and you know where the femoral arteries are located. You go through your iliac crest and you come about midline with the mid-clavicular line, okay? And I have found, while I have been doing these assessments or grading students on these assessments, that those femoral arteries are the ones that students forget to do. And they do not, a A lot of times it's because you do not want to get in somebody's private area, but I'm sorry, if you do not do them, you do not get the points for this. So you need to make sure that you practice going into their femoral area so you're comfortable with it and they're comfortable with it. Usually you should have no sound present. A small number of healthy people, usually if they're younger than 40, may have a normal bruit originating from the celiac arteries, okay? This is a systolic, medium to low in pitch, and it's heard between the xiphoid process and the umbilicus, all right? Note the location, pitch, and timing of any vascular sounds that you hear. A systolic bruit is a pulsatile blowing sound and occurs with stenosis or occlusion of the artery. A venous hum and peritoneal friction rub are very rare. You need to look at the table 21.6 on page 573, and it shows you where you're finding these. Auscultation is no longer the best practice while we're on auscultation for nasogastric tube feeding patients. Okay, no longer do you check placement by auscultation. Auscultation does not play a part in this anymore. They do x-rays and pH testing, and these are your best practices. So for all of you LPNs that have learned how to auscultate for placement, I'm telling you that it's not best practice anymore. Now, on your percussion, let me back up here a minute. On your auscultation of your bowel sounds, you always want to start in the right lower quadrant and work your way up clockwise, okay? Now, on your percussion, you're going to do it the same way. You're going to start in your right lower quadrant, and as you can see from the picture here, you're going to do several areas. 1, 2, 3 areas. 1, 2, 3 areas, 1, 2, 3 areas, 1, 2, 3 areas in each quadrant, okay? You should hear general tympany. You want to percuss lightly on all 4 quadrants to determine the prevailing amount of tympany and dullness. Like I said, you want to move clockwise. Tympany should be predominant because the air in the intestines rises to the surface when the person is laying supine. And by all means, I've seen students that have forgotten to ask their patient to lay down, and they've tried to do this sitting up. Believe me, you will not get your points for that. Okay? Dullness will occur over a distended bladder, over adipose tissue, or fluid or masses that you will hear in the abdomen, or find in the abdomen. Hyperresonance is present when a patient has gastric distension. Okay? So that just means that it's going to be a lot louder and a lot easier to get. The height of the liver span correlates with the height of the person. Okay? So the taller the person, the longer the liver. Also, males have a larger liver span than a female does. Okay? Even if they are the same height. The mean liver span should be 10.5 centimeters for a male and 7 for a female. And in the second picture, you can see where they're measuring the liver span. Okay, to measure the height of the liver, you want to start at the right midclavicular line. You want to begin with lung resonance and percuss down the interspaces until the sound turns to dull quality. You're going to mark this spot. Usually it's in an intercostal space, and then you're going to go start at the bottom in the abdomen, and you're going to start percussing where you hear abdominal tympany, and you're going to percuss up that mid-clavicular line until you reach dullness again. Okay? Normally it's going to be right at your right intercostal or your costal margins, and then you're going to measure the difference between the two. And this is what should be 10.5 for males or 7 for females, or 6 to 12, somewhere in there. Okay? This measurement is a gross estimate of your liver span, and it's usually underestimated by nurses that don't have a lot of experience at this, and even doctors, okay, because of this, because they have a hard time detecting that upper border. All right. Now let's talk about the spleen. Often it's obscured by stomach contents. You may locate it by percussing for a dull note on the 9th to 11th intercostal space, just behind the left mid-axillary line. The area of splenic dullness normally is not wider than 7 centimeters in an adult and should not encroach on normal tympani over that gastric air bubble when your patient's lying down. You want to percuss in the lowest interspace of the left axillary line, and tympani should be the result. Ask the person to take a deep breath. Normally, tympani remains with full inspiration. Okay, the anterior axillary line, you should hear a change in percussion from tympani to a dull sound with full inspiration, and this is a positive spleen percussion. Okay, and if you get this, this means that the patient has splenectomy, okay, or splenomegaly, and they may have to have a splenectomy. It's going to detect mild to moderate splenomegaly, and it will be detected by the splenectic dullness faster than you could palpate it, okay? You can see this in patients with mononucleosis or malaria or hepatic sclerosis. Okay? Now next we're going to discuss the costovertebral angle tenderness, and you will be doing this in your assessment. You can do it now, but it's usually done as the student is assessing the lung fields in the back, and when you get down to percussing, then you will percuss the costovertebral angle for tenderness. Now, what does this do? As you can see here in this photo, you lay one hand flat on the patient, and with the ulnar side of your other hand, you strike your hand. It's called an indirect fist percussion. It causes the tissue to instead of producing a sound. Okay. This is done to assess the kidneys. Like I said, you place that one hand on the 12th rib at the costovertebral angle in the back. You thump that hand with your ulnar edge of your other fist. The patient should not feel any pain. If they do feel pain, it's a good indication that they're having some type of kidney inflammation going on. Okay? Like I said, this is usually sequenced in a complete exam with the thoracic assessment when the person is sitting up and you're standing behind them. Okay, now let's go over some special procedures. These are not on your assessment, but these are handy for you to know. I've actually had students to do a couple of these in the hospital on their patients to help them decide if they had ascites. Okay? But like I said, these are not required for your checkoff. The first one we're going to talk about is the fluid wave, and this is one of them that my students have done in the hospital when they have a patient with ascites, and they just find it just great. What you're going to do is this is checking to see if the patient has any fluid. You're going to stand on the right side of that patient. You're going to hold one hand up against their side. You're going to have another nurse or the patient, if the patient can, push firmly down on the middle of their abdomen, okay? And as you're standing there with your hand on their right side, you are going to reach across and tap their left flank with a firm strike. If ascites is present, it's going to cause a generation of a fluid wave through the abdomen, and you're going to feel a tapping over here on your left hand, which is on their right side. Okay? if it's just gas that the patient has, or if it is adipose tissue, you're not going to feel this change. You're not going to feel that tapping on your hand, all right? Now, let's talk about another special technique for checking for ascites. It's called percussive shifting dullness, okay? And what you're going to do is you're going to have the patient lying on their back, okay, and you're going to start up in tympani on the abdomen, and you're going to percuss down their side here until you get dullness. Then you're going to mark that with your ink pen. Then you are going to have the patient turn onto their side, all right, and that's what this patient is. They're just turned slightly onto their side. And you are going to start with tympani again, and you are going to palpate down until you reach dullness again. You're going to mark that, and then you are going to measure, and this is going to determine for you how much fluid the patient has in them, okay? The reason why you can do this is because the bowels are filled with air, so when they lay down or they shift over to their side, those bowels will float up over that fluid. Okay. Both of this test and the fluid wave test are not real reliable, basically because of the person that's doing them. So anymore, the definitive tool for this is to have an ultrasound study. But if you've got a patient that's laying there and you think they might be accumulating fluid in their abdominal cavity and might be having some ascites going on, you can do this, and then you can make a recommendation that maybe the doctor would want to check them for ascites. Okay? Now, let's go on to light and deep palpation, which is required on your assessment. Okay? Now, I've got some pictures here that shows you, the first one shows you light palpation, the next one shows you deep palpation, and the third one is also another form of deep palpation, all right? Because most people are naturally inclined to protect their abdomen, you need to get some additional measures in use here to enhance their muscle relaxation. You might have to have them bend their knees up. It's kind of hard to tense your muscles up when you've got your knees bent up. You want to keep that palpating hand, as you can see here on the light palpation, you want to keep it low. You don't want to go in at a 90-degree angle. If they see you going in with your hand, that's natural instinct to tense up, okay? You're going to have the patient take some slow, deep breathing in through the nose and out through the mouth. You want to keep your voice low and soothing, make conversation with them that will help relax them. If they're still somewhat tensed, you might try some emotive imagery. Have them close their eyes, talk to them about being on the beach with a nice warm sun, soaking in the sand at their back, feeling warm. You know, those type of things. If you have a patient that's ticklish, this might be hard to overcome. You can always take the patient's hand and put it under yours. They don't perceive themselves to be ticklish. Or you can use their stethoscope, which most people don't perceive a stethoscope to be ticklish either. And keep that hand or that stethoscope under your hand until they get used to your palpating, and then you can remove their hand or take the stethoscope away. All right? With light palpation, excuse me, with light palpation, you're going to use the first 4 fingers, keep them close together. You want to depress that skin about 1 centimeter. As you can tell here from this picture, she's not going in very deep. You're going to make a gentle rotating motion, and you're going to slide all of your fingers together in that rotating motion, okay? Then you want to pick your fingers up to move to the next area. And you're going to palpate just like you percussed, okay? About 3 areas, 3 times in each area, okay? You're going to start in that right lower quadrant again, all right? What are you assessing for here by doing light palpation? You're just assessing for any abnormal nodules or maybe small herniations, bulging, anything like that. Okay? Now, if your patient tends to have some guarding or rigidity in their stomach, you need to determine if it's voluntary or involuntary. Okay? Remember, when you're doing your examination, that if the patient has identified any area that's tender or painful, that you're going to do that last. Okay? You're not in your light palpation. You're not trying to find organs here. You're just trying to get an overall impression of their skin and the superficial musculature that they have. Then after you get done with your light palpation and you make that whole clock around their abdomen, you're going to start right back at the right lower quadrant doing deeper palpation. You're going to use the same technique described in light palpation, but you're going to push down 5 to 8 centimeters, which is 2 to 3 inches, and as you can tell, that's quite a ways. Okay? You're going to move clockwise. You want to explore that whole abdomen. Like I said before, to overcome any resistance, especially if you have someone that is obese, you might have to use the bimanual method, which is your second method here on deep palpation, to where you use your bottom hand is lying flat on them and you're feeling with the bottom hand and you're doing all your pushing with the top hand, okay, in order to get down there deep. Make sure that you know what you're supposed to be feeling. This next slide shows you, you need to know what is underneath each area of the person's skin so that you know what you're feeling in each area, starting in the right lower quadrant. It's going to help you if you can just kind of close your eyes for a minute and picture what is lying underneath that skin. Okay? A lot of times, those of you that don't have much experience, and even some of us that do have experience, when we get to certain patients, will say it all feels the same. It feels like you're pushing on a sofa cushion. Okay? So if you've got these areas memorized of the anatomy and visualize it in your mind, it will help you with your palpation of each quadrant. Okay? When you are doing your palpation, note that it is normal in the left lower quadrant here for them to have a slight bit of discomfort over that sigmoid colon. Okay? Any other tenderness that they complain about should be investigated. Okay? Like I said, the important thing is for you to be able to visualize the structures underneath the area that you're palpating. Okay? So you should not be able to feel a patient's bladder unless they have got an extended bladder. And if you have been a good patient advocate and conscientious nurse, you have allowed that patient to urinate before you start your exam. So you should not be able to feel that bladder. Okay, when you do find something abnormal, you want to document those abnormal findings. If you identify a mass, first you need to distinguish it from any normal palpable structures or an enlarged organ. If you are certain that you've got a mass, you want to document the location, the size, the shape, the consistency. Is it soft? Is it firm? Is it hard? Yeah. The surface of it, is it a smooth surface or is it nodular? Is it movable? Does it move with respirations? Pulsicity of it, does that structure have a pulse in it? And is there any tenderness noted with it? All right. Now we're going to go into palpation of the liver. You're going to begin in the right upper quadrant. You want to place your left hand under the person's back, parallel to the 11th or 12th rib, as you can see here. Okay, you want to lift up with that left hand to support the abdominal contents. All right. Place your right hand in the right upper quadrant with the fingers parallel to midline. As you can see, you want to go straight up. Okay. Push deeply down and under the right costal margin. You want to ask that person, your patient, to take a deep, slow breath. Okay. With every exhale, where they're blowing out, you want to move your right hand in 1 to 2 centimeters. Okay. You might be able to feel the liver bump your fingertips as the diaphragm pushes down, okay, during your inhalation. It would feel like a firm, regular ridge, but on a lot of these patients, you're not going to be able to palpate that liver, okay? There is an alternate method to doing this, and it's called the hook method, where you are going to stand at the person's shoulder and swivel your body towards their feet. On the right hand side, you're going to, like I said, face that person's feet. You're going to hook your fingers, as it shows in this second picture, underneath the costal margin from above. Ask them to take that deep breath, several deep breaths in, and you're going to try to feel that liver bump your fingertips. Okay, one thing that I have not mentioned, and I'm sure Miss Candler has, is you will see in these pictures, you need to make good and sure that you have very short fingernails, because you will be cutting into this patient with your fingernails if you do not. Okay, now we're going to move on to palpating the spleen. Normally, spleen is not palpable. It must be enlarged about 3 times before you can feel it. Okay, that doesn't mean that you don't try. Okay, you're going to reach your left hand under the patient's abdomen and behind on the left side of their body at the 11th or 12th rib, just as you see here in the picture. Okay, and that's to lift up and to support. You're going to have them turn just a little bit. Okay, cock that part of their body just a little bit off of the bed in order for you to be able to reach comfortably. And then you are going to take and place your right hand on the left upper quadrant with the fingers pointing towards that mid-axilla line here. Okay? You want to be just just below the rib margin. You want to push your hand deeply down and under that left costal margin while they are taking deep breaths, okay? You shouldn't feel anything firm. If the spleen is enlarged, you may feel it bump your fingertips. If you do have an enlarged spleen, or you suspect that you felt an enlarged spleen, you want to go down low, okay, real low, and start assessing for these. And you might need to turn them over on their side further in order to feel good. If you do have an enlarged spleen, you need to stop palpating, because the spleen is a very fragile organ and it's easily ruptured, and if you over palpate it, you could rupture their spleen. Okay, if you do have one, you want to describe in the number of centimeters how far below the left costal margin you can feel that spleen. Okay, now we're going to go on to our final palpation, well, our next to last palpation, and that is palpating for the kidneys. Okay, now you're going to search for the right kidney by placing both of your hands together in a duckbill, as you can see here in picture A. Okay, you put the palmar aspects of the hand together, you open up those fingertips, you position it on their right flank, as you see here, right across from the umbilicus. Okay, you're going to press your 2 hands together firmly for a deep palpation, just like you did with the liver and the spleen. You want to have them take a deep breath. Okay, in most people, you might not feel a change. If you've got somebody that's really skinny, you might be able to feel the lower lobe of that right kidney slide through. It will feel like a Nice smooth mass slipping, round mass slipping through your fingers as you do this, okay? You're going to press in and pull out towards you. Okay? It can be normal to feel it, and it can be normal to not feel it. The left kidney is, remember, is going to set about 1 centimeter higher than your right kidney because of the liver. Okay? And you are going to cross over with your left hand and support that area of the patient, pulling up, and you're going to push down with your right hand. And it's not normal to feel the left kidney. Okay? And remember, you're going to have them taking nice deep breaths in and out to help them relax. Now, our last palpation on the abdomen is going to be the aorta. Okay? Using your opposing fingers, you're going to use your thumb and your index finger, as you can see here in the picture. You are going to go a little to the left of midline between the xiphoid process and the umbilicus, and you're going to try to pinch up the aorta. You're going to just hold it in there and lightly feel to see if you can find a pulsation. Okay? Normally you should have 2.5 to 4 centimeters width in the adult. And it will be in an anterior direction that you're feeling that pulsation. Okay? Other special procedures that are not going to be part of your physical assessment checkoff, which will help you in your, when you get into the hospital setting, are checking for acute rebound tenderness, which is your pictures A and B here. And what you will be doing is going right straight down, pushing nice and slow and deep. Hold it there a second, and then release it real fast, okay? And if the patient tells you that they've got pain on the right lower quadrant, you're going to want to go to the left lower quadrant to do this, okay? Like I said, push down slowly and deeply and then lift up quickly. Normally, there should not be any pain response on release from this pressure that you're putting on them. Okay? It makes the structures that are indented by palpation rebound suddenly. Like I said, normal is a negative response. There should be no pain. When you perform this test, you want to do it at the end of your examination, because if it does cause pain, you're going to have muscle rigidity from then on, okay? And if you have a positive response to this, it is a reliable indicator of peritoneal inflammation, which can accompany like appendicitis, okay? Now, another one that we're going to talk about that we don't have a picture for here is the Murphy's sign. Normally, when you palpate the liver, you should have no pain. If the person has an inflamed gallbladder or cholecystitis, you're going to have pain. You're going to hold your fingers up under the liver border and ask that patient to take a deep breath. Normally, they can take a deep breath without any pain. Like I said, if they have issues with their gallbladder, you're going to have a positive sign and they're going to have pain with this. Okay? Now, this is not done a whole lot anymore, and the reason why, especially on older adults, the reason why is patients older than 60, about 25% of them is all that are going to have any abdominal tenderness when they do this. Okay? And like I said before, these are not on your checkoff, so, but they are good to know for you if you get into practice, okay? And when you have a positive sign, it's because the descending liver is pushing on that inflamed gallbladder, okay? It's pushing it up against your your hand that is palpating, and that's what causes them to have some sharp pain, and they will abruptly stop taking that breath, okay? Now let's talk about our last one here. It's the ipsilasis muscle, and I apologize for the pronunciation of that. It's a very tough word for me to say. Muscle test, and you're going to have the person lying supine, and that's this bottom picture down here, okay? You're going to have them lift their right leg straight up, only flexing at the hip. You don't want any knee flexion, okay? Keep your ankle neutral too. And then you, the examiner, are going to push down on the lower part of their right thigh as they try to hold that leg up. If this test is negative, the patient won't feel any change, okay? If you perform this test and it's positive, they're going to have pain, and this is a good indication that they have appendicitis, okay? Because that muscle is inflamed, and it lays right there close to the appendix. All right? And they will describe their pain in the right lower quadrant. Okay? Now, this is the end of the abdominal assessment. I hope this helps. As I have stated to you before on all of my other ones, I have some additional YouTube stuff that I am going to post with this. If you have any questions or any difficulty, please feel free to contact me. I appreciate your time. Thank you very much, and hopefully I'll see you soon.